All right, so we're done with cancer. So we just discussed the most common causes of most common cancers, but now let's look at the rheumatological causes that can cause fatigue. So these people have fatigue, and then in addition to that, their chief complaint or another symptom may be muscle aches and joint pains. So this is basically the biggest symptoms that they will come in with. And the main diagnosis that we might want to consider would be fibromyalgia, polymyalgia rheumatica, rheumatoid arthritis, and lupus. And there are many others, which for the sake of time, I'm not going to go into detail for all of the other diagnoses, but we'll just focus on these 4 real quick here. So this is patient with fibromyalgia. Again, fibromyalgia is a controversial diagnosis. A lot of people don't believe in it. A lot of people don't want to diagnose it. But it's been published in the literature. So basically this is still like an evolution process. We don't know what exactly it is. It basically is just a hyperalgesia of the central nervous system, and people have pain, widespread pain in multiple areas of the body, and chronic fatigue for more than 3 months. That's basically the hallmark. And in the past it used to be 11 out of 18 tender points, but it's not been validated. So this diagnostic criteria is not, I think it's not going to stay around for a long time. But in the past, people used to just count on the 11 out of the 18 tender points. The next is polymyalgia rheumatica. So these patients, the key feature would be, in addition to muscle aches and joint pains, they're going to be different from fibromyalgia patients, because you can see that here fibromyalgia is just tender points and aches and pains and fatigue, right? But in polymyalgia rheumatica, they have specifically, they are older than 50. They have pain usually in the shoulder girdle and pelvic girdle. They have morning stiffness, some sort. It's usually not more than an hour, like we see in rheumatoid arthritis, but it's more than half an hour. And they can have some sort of joint swelling. The key feature or the key item to make the diagnosis for polymyalgia rheumatica would be a diagnostic therapy. So if you give them steroids, they will respond, and if they don't respond, then it's not polymyalgia rheumatica. Then you might want to fall back on fibromyalgia. If they do respond with all of these features and they don't have any positive ANA, then maybe it is polymyalgia rheumatica. So response to steroids with generalized aches and pains, especially in those 2 girdles, and stiffness less than half an hour is a diagnostic criteria for polymyalgia rheumatica. Their ESR may be still high, more than 40. So that is a common thing between polymyalgia and maybe rheumatoid arthritis. Then there is chronic fatigue syndrome or systemic exertion intolerance disease. So you can see it's a very vague scenario. I don't know. I don't make this diagnosis. I think this is not a very well-known disorder. So, but it's been published. I don't know. These are the people who just have unrefreshing sleep and they just are very tired. And there is a diagnostic criteria that they get better if they don't exert themselves. So I think anybody will. Okay. So next is rheumatoid arthritis patients. So you can see it's very similar to polymyalgia rheumatica, except for they have symmetrical joint pain more than three joints, and then they have morning stiffness that lasts more than an hour. And in addition to swelling, they have a problem in the large joints and the hand joints. So usually you'll see hands and knees and the pelvic joints. And then, of course, you all know they have swan neck deformity, classic for rheumatoid arthritis. They have radiographic findings and rheumatoid nodules, possibly on the skin exam. So they have an ESR. So when you do their labs, their ESR will be high. Rheumatoid factor may be positive. And then lately we have CCP, which is citrulline cyclic peptide, that is going to be high. And then C-reactive protein, which is just a regular inflammatory marker, that may be high in these patients too. But then this is going to be positive in many infections too, so we don't count on it. The main tests are ESR, rheumatoid factor, and CCP. Here is a patient with swan neck deformity of the fingers. Here is a patient with rheumatoid nodules, so you can see the nodules are right here. Here is a patient with X-ray, so you can see that there is some bone erosion going on in a patient with rheumatoid arthritis. The next is lupus. So lupus, all right, so that is another very Huge thing. Lupus, again, like I would say, like maybe Cushing and cirrhosis, this can affect many different parts of the body. You all know about it already. It's a very common and a very popular diagnosis. A whole lot of general population also knows about lupus, but therefore it makes it very confusing because there are so many things that can happen with lupus. So then it becomes hard to figure out when exactly do you call it. So luckily, lately, American College of Rheumatology has come up with the criteria, and I'll talk about that here in a second. But anyway, these are the things that can happen in lupus. So you can see fibromyalgia, rash, joint pain, vascular abnormalities like Raynaud phenomena, oral ulcers, eye problems, photosensitivity, low-grade fever, and then some hematological abnormalities, clotting disorders. And the cardiovascular effect would be Liebman-Sachs endocarditis. So these patients can develop endocarditis, and it's not a septic or infective endocarditis, it's autoimmune endocarditis. So in the vegetations that they see, based upon that, this is called Liebman-Sachs endocarditis. So remember this very well. They can develop heart blocks or conduction abnormalities. For example, when you see on the labs they have these antibodies present, then these patients are more likely to get heart block. So the antibodies are going to be anti-ROS A and anti-LAS B. So remember these two antibodies. And then they can have pulmonary effects. They can have interstitial lung disease. They can have pleural effusions because of that. Some neurological manifestations. These people can develop lupus nephritis. This is relatively more common than some of the other systems involvement. So renal is going to be more common, and then they can develop hepatic lupus too, and then some patients have lymphadenopathy and splenomegaly too. So you can see there is a whole host of things pretty much everywhere in the body. And then some drugs can cause lupus-like symptoms. So hydralazine is the most notorious, which is a blood pressure medicine. So just keep that in mind. The labs to draw would be ANA, that will be positive, and then this is going to be positive in many other situations. So you can see it will be positive in pretty much all the other rheumatoid conditions too. But in addition to that, anti-DNA, either double-stranded or single-stranded, will be positive in lupus. Then you can draw also anti-smooth muscle antibodies, anti-phospholipid antibodies, and then of course ESR and findings of hemolysis. So these are the things that can be drawn, but the most specific diagnostic test would be anti-DNA, double-stranded or single-stranded antibodies. So these are the diagnostic test for lupus. So here is a quick deforming lupus arthritis. So these people can develop a lot of deformities in the joints too. And then here is a patient with Raynaud phenomena. So you can see discoloration at the tips of the fingers and exposure to cold. All right, so because lupus has a multi-system involvement, American College of Rheumatology has come up with the criteria. So they just say that remember 4 out of 11. So we just have to remember 11 features if present. If 4 out of those 11 features if present in a patient, we can call that lupus. So patient doesn't have to have all 20 or whatever number of things. And also not anybody who comes in with joint aches and pains and maybe some photosensitivity should be called having lupus. So there is a specific criteria. So what is that? So you can see I've developed a mnemonic for it. So these patients, let me look at that. Let me show the mnemonic. Okay, wait. So patient can have a rash, hematological problems, immunologic problems, which basically this means ANA. Hematologic means basically either any CBC problem, any anemia or thrombocytopenia, rash, any lupus kind rash on the face usually, any neurologic problem, for example, any oral ulcer, so that is basically your mucosa, any serositis, any arthritis, which most patients are going to have this anyway, then positive ANA, positive renal test, like a elevated creatinine or proteinuria usually, and then photosensitivity. So this all stands for rhino-SARP. So remember rhino-SARP, that is a mnemonic that I made, but of course you can memorize it any way you want. So if you see that any 4 of these 11 is happening, then it is lupus. And you can also think about it in another way. So you can look at the organs. So you can see skin, mucosa, eyes, joints, renal, and CNS. So if you just look above the shoulders, that will cover most of your organs. So your skin and mucosa, eyes and CNS, that's all above the shoulders. If you just look above the shoulders, most of the organs are already covered. And then of course you look at the joints and you look at the kidney function. And if things are positive in here, plus if there are some labs positive like ANA or CBC or immunologic labs present, then you will make the diagnosis. So that's how I approach the patient, or that's how you can do it too. If you have any of 4 of these present, then it is lupus. So basically what I'll do, I'll look at the patient, and if they have any skin problem, any mucosal problem, or any eye problem, or any CNS problem, those 4 alone will actually give you the diagnosis. But if you have, let's say, 1 or 2 of those and they have a joint problem, which usually they all have, then you will add labs and you'll say, okay, this makes the diagnosis of lupus. And here is a pneumonic rhinosarp. Alright, so the next category is chronic infections. A whole lot of chronic infections can cause chronic fatigue. So usually it's the viral infections, but it can be bacterial, parasitic, or fungal too. So I'm not going to go into too much detail about all these 3, but we'll talk a few viral infections here. So low-grade fever, tonsillitis, cervical lymphadenopathy, if present, you'll think about mono. Low-grade fever, cold symptoms, opportunistic infections, and weight loss, if present, you'll think about HIV. And then low-grade fever with fatigue and hepatic failure, and of course anorexia, and all these. Any of these 2 combinations, you will think about hepatitis B or C. So these are the most common causes of fatigue as when it comes to virus infections. So you can see all of these infections come with high-risk behavior. So high-risk behavior comes with a price tag. So people can develop these infections. So that's why when you are thinking about it, you will ask the patient about this high-risk behavior. So there will be a reason to ask about this question if they've been having multiple sex partners, or if they have used IV needles and drugs and all that stuff. So that's where this question becomes legitimate if you're thinking about these diagnoses, right? There is just a hepatitis B serology. So you already are familiar with it. So you can see that hepatitis B surface antigen is going to be present early on, and then antibodies are going to be present only for IgM. So IgM will be present early on, but if the IgG is present, then that basically means that this has been too long, or too much time has lapsed for hepatitis B infection. And you're all familiar with it already. I know you went through all of this, so this is just a review. Hepatitis C, same thing. Anti-HCV antibody is going to be present for a very long time. Symptoms will be present early on, and hepatitis C virus will be present early on. So a lot of patients who develop hepatitis C or even B, they shed off their virus after a few months. So it doesn't stay forever, but the antibodies are going to be present. So real quick about a little bit more about the viruses. So your HIV, of course, you can see this is how you will make the diagnosis. You will get the HIV antibodies, and then HIV viral load, and CD4 count. So these 3 are going to be essential to make the diagnosis for AIDS or HIV AIDS. And then you'll see that these patients have a lot of opportunistic infections. And Epstein-Barr virus patients will have a positive monospot test, or they have positive IgM or IgG antibodies for EBV, and then on labs you'll see that they have a lot of lymphocytosis. So if you see lymphocytosis on the CBC with differential, then you will think about it. If a patient has fatigue and they've come in with low-grade fever and chronic malaise. These patients can develop a complication of splenomegaly. That's why we tell them not to engage in contact sports for a while, but then also they can develop Burkitt lymphoma. So this is especially going to be true in Asian population when after they get the infection, they develop a lymphoma. Usually it's on the face, so it's a mass that grows, and then it's called Burkitt lymphoma. So keep that in mind. Then human herpes 6 virus, that's another benign virus. It just causes fatigue, low-grade fever, and myalgias and rash. So I just mentioned it here because this is a relatively more common virus, and it kind of stays for a while. So that's why you can think about it when you are evaluating a patient with fatigue. And then HIV patients can also develop a skin cancer. It's called Kaposi sarcoma. So they develop like a skin ulcer. This is one form. This is a form of sarcoma. So there are many other ways they can present, but this is one of the pictures that I have. So Kaposi sarcoma in HIV. All right, next is polypharmacy. So that's one of the last categories, or almost, we're almost there. So polypharmacy is a situation when patients are taking too many medicines. So what are the most common medicines? So usually it's not just necessarily one medicine, it's a combination of a few that just have additive effect or summative effect. So patients, when they take sedatives, and I know you haven't done the psych drugs yet, but just keep in mind, if they are taking benzodiazepines and barbiturates, that's going to definitely cause fatigue. If they're taking anything to sleep, obviously that's going to cause fatigue. And then patients, when they take antidepressants, so pretty much all, with the exception of a few, like paroxetine, all the like Lexapro and all the other SSRIs that are used, although they are great medicines for depression, but when one of the side effects for these drugs is fatigue. So remember, the SSRIs can cause fatigue. Then antipsychotic drugs for bipolar disorder and schizophrenia, typical and atypical, they can cause fatigue. Antihypertensive and lipid lowering agents can cause fatigue. So for example, your beta blockers and centrally acting drugs like clonidine that lowers the blood pressure, they will cause fatigue. Statins, which are basically your lipid lowering agents, they're very powerful drugs that can lower the cholesterol, but they can also cause fatigue along with hepatotoxicity and muscle injury. In addition to statins, your lipid lowering agents, for example, gemfibrozil and your the Tricor, or the drugs that can lower the cholesterol levels, almost all of them can cause fatigue, except for omega-3 fatty acids, which come from diet, and you can also buy them over the counter. Those are the only ones that will spare you, basically. Then anticholinergic drugs, for example, Benadryl and hydroxyzine, can cause fatigue. These are drugs used usually temporarily for allergies and itching and stuff like that. And then people, when they abuse drugs, for example, narcotics and alcohol, when they withdraw from it, they can get extreme fatigue. And then, of course, there are many other drugs that can cause fatigue, and that fall under the umbrella of polypharmacy, but these are just the main ones. And finally, chronic depression, dysthymia, which is basically just chronic depression, anxiety disorder, somatization disorder, and even psychological abuse can cause fatigue. All right, so finally, I think we have done it. We finished the talk, and we just quickly going over this slide that I showed initially. This is basically just the really high level findings for all the different problems. What are the main symptoms or signs or lab findings that people present with, and then how you can presence of one thing should lead you to a particular diagnosis or a disorder. And then how do we approach the patient? So basically, this is just a one illustration. So the first thing to do would be, of course, ask about duration. If you see a patient who has fatigue, after you rule out any red flags, of course, there is almost no red flags for chronic fatigue except for, I would say, Addison or adrenal crisis. And that usually will present with acute fatigue. But for chronic fatigue, usually people don't have a red flag. You should have a prior probability or all the differentials in your head already. But the first good question to ask would be about duration. So if patient says, yeah, they've been tired for a couple of days, then really there's not much to be done, because that can resolve on its own. When it's a few weeks and chronic, then we can take history and ask more questions. So because sleep disorders are so common that and just extremely common, that would become the next logical question. So you think about sleep disorders, you ask about quality of sleep and duration of sleep. If it's not too much, then obviously you got your answer. If people are just not sleeping right, then either it's sleep apnea or insufficient sleep hygiene. And then if they say no, they actually are sleeping too much, they actually are not, it's not the problem, then you will go down this list. So then you'll cover all these diagnoses, the rest of the diagnosis basically in this talk. So then you will expand your questionnaire. And the next set of questions, you can approach it anyway, but basically based upon what are more common in general population versus less common, I start with myalgias and arthralgias, and if they have that, then you gotta think about connective tissue disorders and fibromyalgia. If the patient have too much weight gain, then I ask about, then I will look for thyroid disorder. If they have buffalo hump and moon phase or any other feature that obviously you can identify on by talking to them, then you got to think about Cushing. If in addition to weight gain, because you're thinking maybe they're developing metabolic syndrome, you might want to ask them about polyuria and polydipsia. Even if they don't have it but they are obese, definitely check them for diabetes, because that's one of the screening criteria for diabetes. Anybody with any features of metabolic syndrome or even family history of diabetes. So I'll look for diabetes, and of course diabetes can happen in any two ways or multiple ways. And then if they just have only polyuria and polydipsia but no weight gain, then you can also think about diabetes insipidus or high calcium levels. So here is where you will draw your labs for metabolic panel, including calcium and glucose and hemoglobin A1C. Let's say they don't have weight gain or any of these present, instead they just have weight loss. So obviously then it will be a signal for you to look for any malignancy. So you will ask about all the specific features of all the different kinds of cancers, especially the most common cancers that we covered here. So you look for that. Patients who just have weight loss but you have figured out that maybe they don't have cancer, you will of course draw other labs to make sure they don't have HIV, especially if they have a high risk behavior in the past, your GL population, your IV drug users, and multiple sex partner patients. And then let's say in addition to weight loss they have a low grade fever or they have cough and hemoptysis, then you will look for tuberculosis. Another important thing to keep in mind would be review their medications. A lot of the times this actually is sometimes more common than many other diagnoses, especially in the elderly population. If they're just taking a whole bunch of medications, you gotta look at it more critically and make sure that they're not just taking one medicine to cover the side effect of another one, and then they just keep on adding more and more, and sometimes they don't even know why they're taking their medicine. So just keep that in mind and maybe eliminate some of the medicines that are unnecessary, and this way fatigue may get better. Then depression questionnaire is actually a must questionnaire. People should be screened for depression if they have fatigue, because this is a very common diagnosis. A whole lot of population has depression, but they don't complain about it necessarily. People usually most of the patients who have depression, they don't come in and say I'm depressed. They come in and say either they are fatigued or they are just sleeping all the time, or they'll just complain about other things, or they can say I'm just not sleeping right, or I'm eating too much. So there are all kinds of other indicators. So always look for it. If they have other physical exam findings or even symptoms, for example dyspnea and lower extremity swelling, then you will look for all the chronic organ diseases, for example heart failure, liver disease, and kidney disease. And let's say if they have any chronic blood loss, so you will think about the anemia. So this is, of course, you already know what kind of questions to ask. Female patients, you'll ask about menorrhagia. For older population, you will ask about change in bowel habits, or any kind of thing, any kind of history feature that can cause blood loss, chronic NSAID use, or even new drug use, for example anything that can cause hemolysis. Patients who just have hypertension and nothing else, and they just have fatigue, you might want to think about hyperaldosteronism, but then hypertension is so common that it doesn't necessarily help us too much, but you can look for aldosterone levels, especially if their potassium is low and they have hypernatremia. So you'll definitely look for this. Patients who have hypertension, obviously this will be one that will be more acute, and then you will look for adrenal insufficiency. So you can see there are clues, diagnostic clues, and there is a way to approach the patient. The first question would be duration, and then of course you can ask multiple other questions. In addition to duration, onset question would be important. So not necessarily asking what is the onset of your fatigue. You might want to ask at the time when you started feeling very tired, did any of the other features start to happen. So let's say if somebody has fatigue and they have just weight gain, but they've been overweight for many years and it's not necessarily new, then it doesn't necessarily automatically link with fatigue, because if their fatigue started just a few weeks ago. So you might want to be cognizant of that factor. So therefore, always look for features that started on along with the same duration when the fatigue started. So I think that is pretty much it. I'll end it here. Hopefully it was helpful, and feel free to send me any questions if you have any, and I'll be happy to reply. Thank you so much for your time.